So good morning from New York, and good afternoon and good evening wherever you are, or good night maybe. So thank you so much for Pakistan Society of Medical Genetics and Jinnah Sindh Medical Alumni and National Institute of Child Health, which we are hosting this joint session for medical genetics. And to start with, I just wanted to ask our president of alumni, Dr. Zeenat Safdar, to just welcome everyone, and then I will introduce the host and we move on. Zeenat Safdar, Dr. Zeenat Safdar.
Ji, thank you, Rizwan Bhai. This is truly a privilege and an honor to host, to partner with the medical genetics and the PSMG and also with the NICH in Pakistan to bring forward this first truly international, I think it is the inaugural genetic meeting, which is in collaboration with our alumni here in US and Canada and with Pakistan. So I'm looking forward to this meeting, and I hope that this will be one of many in future.
Thank you so much. And if Dr. Tariq Rafi is here, I'm not saying him, but he is.
I'm there. I'm
Okay,
there, Rizwan.
please, if you, Tariq Bhai, if you say a few words. And Dr. Tariq Rafi is the Vice Chancellor of our alumni, and he's been very, very helpful for all the academic programs we have done so far. Dr. Tariq Rafi.
Thank you, Rizwan. I'm thankful to all those who have arranged this meeting, especially the Pakistan Society of Medical Genetics. I'm really happy to see that this dream of Rizwan you come true to start a genetic program in Pakistan. And I think because we have been discussing with me for a long time, and I think Jamal has participated and given us full support to that. And I'm thankful to you for establishing the lab at NICH. Definitely, medical genetics is something which is new in Pakistan. There are very few labs. We have got a number of genetical problems, and you are aware of that because of the interfamily marriages that we have in Pakistan. This has become a very important issue. Now, to the program of yours, which I'm going through, is to train people for counseling purposes and for training them to do genetics. Is definitely something which is we are looking forward because at the end of the day, whatever program that you take place here is going to benefit our patients. Definitely, the new advancement that takes place in the West will now be transferred through these mechanisms of yours, the meeting and arrangement and workshop, to our doctors in Pakistan. Thank you, Rizwan, once again. Thank you all those who have arranged this meeting, and thank you very much once again. Thank you.
Thank you, Dr. Tariq. And so with that, can you just put up the next slide? I want to introduce the host and moderator of this meeting, Aisha Tawfiq. Aisha, can you put the slide on, your introductory slide? Yes. Aisha works as an oncology genetic counselor at Matera. She has over 5 years of experience working in rural oncology clinics. She's also passionate, I would say very, very passionate about ethics and teaches a course on ethics, genetics counseling at UCSD Extension Program. She has a master's in genetics and counseling from Stanislaus State University and is certified by American Board of Genetic Counselors. I have to tell you, Aisha and one of the panelists, Myla, are the heart of this whole program, and they're bringing more and more people in, and they are passionate and committed to bring genetics counseling to Pakistan. From here on, Aisha will be the host and conducting the meeting. Aisha, please take over.
Thank you, Dr. Naeem, for that kind introduction. And again, it's an immense honor to be moderating this vibrant discussion that we're about to have. Before I get started, I would like to do some housekeeping rules rather quickly, and then we'll jump into the heat of the action. So everyone in the audience, if you are not already, please mute yourself and unmute yourself when the questions are going to be posted to you only. Also, please add any questions that you might have in the chat box, as we will have Q&A session at the end so that you can, your questions should be answered at the end. We do request that any questions that are pertaining to particular cases, be refrained from adding in the chat box. You are more than welcome to email them to us. Our email address will be provided at the end. And finally, at the end of this webinar, we would like to administer a short survey, link to which will be provided to you in the chat box towards the end. Those are all the housekeeping rules. So let's get this party started, shall we? So sequence of events will be as such. I'm going to introduce the panel first, some amazing people that we have with us today. I will then be giving a short presentation on Pakistani Society of Medical Genetics and what we have done thus far in our little capacity with the collaboration with NICH. And then we'll start the discussion with the panelists. And finally, like I promised, we will have a Q&A session with the audience. And so, yeah, let's get started with the panelists. So we have an esteemed panelist, a group of panelists here. So please give a thunderous round of applause to all of our amazing panelists. Keep it COVID friendly, please. It's virtual round of applause. And then in no particular order, I'm going to introduce these panelists. So first up, we have Syed Jamal Ahmed. Dr. Ahmed is a molecular pathologist and a clinical geneticist at Kaiser Permanente, Southern California. He is a graduate of Dow Medical College and completed his clinical genetics training at the University of Miami and fellowship in molecular genetics pathology from Mayo Clinic. He is certified by American Board of Pathology and American Board of Medical Genetics in clinical pathology, clinical genetics, and molecular genetics pathology. He has a special interest in hereditary cancer genetics and has authored and co-authored numerous peer-reviewed articles. He's also the architect behind this whole shenanigan, so please direct all your strongly worded comments in his direction, please. Thank you. Next up, we have Dr. Salman Kirmani. Dr. Kirmani is a medical geneticist and a pediatrics endocrinologist at Aga Khan University. He is an associate professor of medicine and pediatrics. He's also the chair of Division of Women and Child Health and interim chair of Department of Pediatrics. He's a graduate of Dow Medical College and completed his residency and fellowship training at the Mayo Clinic, where he also served on the faculty. He is certified by the American Board of Medical Genetics and the American Board of Pediatrics. He has been instrumental in developing the clinical genetics program at his institution and serves on the board of many patient support and advocacy groups. He has over 50 peer-reviewed articles to his credit, along with book chapters, and is actively involved in research. And next up, we have Dr. Jamal Raza. Dr. Raza is the executive director of the National Institute of Child Health in Karachi. He is a professor of pediatrics and endocrinology. He is a Dow graduate and a member of the Royal College of Physicians, London, and a member of College of Physicians and Surgeons, Pakistan. He has co-authored many peer-reviewed journal articles and is heavily involved with the postgraduate education at the NICH. He served as the General Secretary of Pakistan Pediatrics Association from 2012 to 2014. Next, we have Dr. Shama Maniam. Dr. Maniam is a professor of obstetrics and gynecology at Jinnah Medical and Dental University and a senior consultant OBGYN at South City Hospital. She did her postgraduate work in UK. She is a fellow of Royal College of Obstetrics and Gynecologists. She did her fellowship in fetal medicine and has a certificate of Royal College of Obstetrics and Gynecologists in advanced ultrasound scanning. She is also the only certified fellowship trained fetal medicine specialist in Pakistan. I'm sorry, Dr. Manim, there's a grammatical error. There should be an exclamation point, not a period. And that's pretty fantastic. She pioneered the fetal medicine service in Pakistan and set up the fetal maternal service at the Aga Khan University Hospital. Dr. Zara Hassan is a lead professor at the Department of Pathology and Laboratory Medicine at the Aga Khan University. She works as a consultant molecular pathologist for infectious disease, immunology, and molecular genetics. She expanded the scope of molecular genetics for clinical genetics at the Aga Khan University Hospital Laboratory Clinic, establishing sequencing and microarray-based tests for common genetic diseases in Pakistan. During her tenure as the head, as a section head, the laboratory gained College of American Pathologists accreditation. She is the current president of the Association of Molecular Pathology in Pakistan and remains interested in expanding the scope of molecular genetics and testing in the country. Next, we have our social butterfly, Dr. Rizwan Naeem. The list of his accolades will go from here to the moon and back, so we'll try to keep it short for the sake of time. Dr. Rizwan Naeem is a professor of pathology at Albert Einstein for Laboratory Genetics Fellowship Program. He is a graduate of Sindh Medical College and executive director of Sindh Medical College Alumni Association. Currently, he's serving as
Aisha, we can't hear you.
Oh yeah, we have lost the host. Aisha, we can't hear you.
as a president of Genetics and
Aisha, we can't hear you.
So Aisha, your phone is probably, your device probably is not, Aisha, are you there?
No.
Okay, so let's continue with the program, I guess. Myla, you can please see if you have questions handy. We have introduced all the panelists. I know we are missing
No,
one
there's still a few
panelist.
panelists left to
So
be.
why don't you introduce them, Myla?
I can. I don't have the slides to introduce them, however. Oh, looks like Aisha might be back. Or
Rabia Aziz is one of the panelists, if I'm correct.
Rabia Aziz is one of the panelists, Rabia. We don't have your picture up,
Rabia
so maybe you can just wave so everyone can know who you are. There, she's waving right there. So Rabia is the founder of a program called Special Needs Pakistan. And this is an organization that really works as a patient advocate organization and helps families who have individuals with a special need, a disability, or genetic syndrome. Aisha is very active. Rabia, sorry, is very active. Aisha, I see you back, so can you take over? We can't hear you, you're on mute.
Yes.
sorry for the technical difficulties. I'm so sorry. It's going to take me just a second to log back in. Okay. So I'll skip to Rabia. All right. Thank you, Myla.
Aisha, you were introducing Dr. Naeem at the time when you went on.
That's okay. Move on.
Okay.
I need to save time.
All right. And I saved the best for last. We have with us Rabia Aziz Rizwi. Rabia is the founder of an online support group called Special Needs Pakistan and a social care initiative called Alia's Care Packages. The idea was sparked after the birth of her daughter, Alia, who was born with Apert syndrome. Upon finding no support, neither for herself nor for her daughter, she began talking to a small group of children and their parents about diversity and inclusion of the differently abled. Their Facebook group is now 6,000 strong. She's a motivational speaker, facilitator, social worker, and a caregiver. She has spoken at many platforms, including Facebook, TEDx, WOW, and other social media platforms, focusing on the rural and low-income areas and educational institutes. So a very warm welcome to you all. As an audience, really, what more can you ask for in a panel? We are certainly in for an amazing, amazing treat. So that's all for introductions. We do not have
Myla, we need to introduce Myla.
Oh, skipped over. I'm sorry, Myla. I'll go back. So I really did save the best for last. Okay, sorry. Myla Schwach is a genetic counselor and assistant professor at the McGovern Medical School at University of Texas, Houston. She received her bachelor's in genetics from Ohio Wesleyan University and a master's in human genetics and genetic counseling from Stanford University. She's a senior genetic counselor, and as a senior genetic counselor, Myla is involved in the various pediatrics and adult genetics clinic. She's heavily involved in genetics education for the medical students at the McGovern Medical School and is involved in teaching and supervising students at the University of Texas Genetics Counseling Program. Myla is a member of the National Society of Genetic Counseling, Association of Professors of Human and Medical Genetics, and the Organization of Teratology Information Specialists. Amazing accomplishments here, Myla. Okay, so we have no conflicts of interest declared by the panelists, except for the conflicts of interests that are already mentioned as our employers. Now I would like to give you guys a quick overview of medical genetics and what work we have done so far with our PSMG organization in collaboration with NICH. So there are really two fronts where medical genetics is currently being conducted. At the front end of things, we have the medical geneticists that are doctors that went to medical school and have specialized training in hereditary disorders and are also board certified. We also have the instrumental genetic counseling team, and our genetic counseling team is usually comprised of individuals that have master's level coursework in hereditary disorders and counseling techniques and are also board certified. On the back end of things, we have our laboratory geneticists, and our work is never ever complete without our support from the back end. In laboratory genetics, we really can be divided into three different sections: biochemical, cytogenetics, as well as molecular. And the personnel list, as rather long as you can tell, goes because a lot goes into getting genetic testing done. So you have your laboratory directors, you have genetic counselors, you have laboratory technician staff, bioinformaticians, a report assembling team, as well as the data curation team. So as you can tell, a lot goes on in the back end. So you must ask for yourself, what are some of the goals of this genetic service model? So really, it can be divided into four major subcategories. So the first is reaching accurate diagnosis. How can a person be informed that what they have is a hereditary or genetic syndrome? So it definitely includes taking a very thorough, robust family history, a physical exam, and laboratory studies, including cytogenetic studies, radiology studies, as well as molecular DNA studies. Next up, we need to be able to estimate the risk of recurrence for that family or for that patient. What are the chances that the next child or the next member of the family may be diagnosed with the same condition? And so that's where, again, as you can see, family history is one of the main tools that we use to make sure that we know what the inheritance pattern might be. And then, of course, there are other statistical models that we also utilize, including Bayesian and Mendel's models. And then something very close and dear to my personal heart is the concept of genetic counseling. What is genetic counseling? Really, it is a conversation that we have with the patients where we are able to communicate with them what are the risks that they will face. What are some of the natural history of the disease? What are some of the treatment options that are available? And of course, the psychological and psychosocial aspect of those things can never be underestimated. And then, of course, we have decision making, and now a family or a person has to make very critical decision that could be life altering. So, of course, historically, genetic counselors have erred on the side of non-directiveness, but there are more and more concepts of directive genetic counseling as well, where management can be very, very helpful in reducing the disease status. And of course, what options are available to patients? What are some of the religious beliefs, social status, economic status, community influence? All of those things go into our genetic counseling services. You must have heard people say, you know, genetics is in this specialty or that specialty. So I have a long list of subspecialties where historically genetic counseling has been offered, including prenatal, pediatrics, neuro, metabolics, endocrinology, oncology, cardiology, and pharmacogenetics. However, in today's term, and I've underlined and bolded it and cannot be emphasized enough, that genetics is now synonymous with medicine. There is not one area of medicine that is spared from genetics. So it's quite important that we all focus some of our attention to genetics, if not all of our attentions. Okay, so let's talk about the Pakistani Society of Medical Genetics. The four of us, Maila, myself, Dr. Ajaz, and Dr. Rizwan, have this goal and a mission that we're trying to accomplish with all of your help. So I would like to introduce Pakistani Society of Medical Genetics to you all, and really hoping that you would come and join our efforts. So our mission is to enable the provision of affordable medical genetic services to the people of Pakistan, and to create awareness of genetic disorders through education, community outreach, as well as research. So our aims and goals are fourfold. We would like to start off with clinic services. The US-based geneticists and genetic counselors are working together to provide clinical genetic services through telemedicine. We would like to expand this, of course, to people in Pakistan, to empower them in Pakistan. Of course, we have tremendous support from laboratory services. We cannot work without laboratory services. They're quite essential. And our goal is to have affordable genetic testing available for the residents of Pakistan. Of course, genetics education is quite important. We are actively working towards increasing the presence of genetics professionals in Pakistan by starting a genetics certification program. And of course, a community outreach, which is really near and dear to my heart. It is increasing awareness of genetic disorders in Pakistan through community outreach and creating social support groups and networks. And I want to give you a little peek into what we have done so far. We really got together in summer of 2020 and have done some amazing work with collaboration with the National Institute of Child Health. So I want to give you a little peek into our world. So we've started this telehealth medicine clinic, and it's staffed by Dr. Ahmed, who is a medical geneticist, myself, and the presenting doctors at NICH, as well as Misbah Hanif, who is our genetic counseling trainee at NICH. It's of course also attended by the patients. The affected children are there, their parents are there, as well as extended relatives. We have had mamus and mamanis and chachus also attend, which is fantastic, which is perfect for us. And we have so far counseled individuals and families on the following conditions that include chromosomal aneuploidies like Down syndrome and Turner syndrome, as well as single gene disorders, including autosomal recessive conditions like cystic fibrosis, spinal muscular atrophy, as well as X-linked conditions like Duchenne muscular dystrophy. So like I mentioned earlier, there are really fascinating work that's being done at NICH. Misbah Hanif, who is our genetic counseling trainee, is a PhD candidate. She is our clinical coordinator there. She helps us with taking pedigrees, and she also helps in clinic coordination, like I said already. So we're counseling and we're training her in genetics and hereditary conditions, also on counseling theory and techniques, and also help with family history and other clinical history tools. And of course, we also have the presenting physicians that has so far included many doctors, including Dr. Jamal himself, Dr. Mohsena, Dr. Shazia, and Dr. Arit. and they present cases to us. We have a little pre and post genetic counseling session meeting with these presenting physicians, and we talk about things like natural history of the conditions, inheritance patterns, genetic testing requirements for diagnosis, as well as counseling techniques. So far, in terms of laboratory collaboration, we have on-site cytogenetics lab at NICH that has been utilized. We also have currently working on contracting with US-based molecular labs that include many private labs in the United States, so not focusing on any one. And the real idea is to have affordable testing for the layman in Pakistan. We switch our focus to the aims of the current shenanigan that we have going on. We have our aims as threefold. We want to highlight the current status of medical genetics in Pakistan. We want to assess the needs of future of medical genetics in Pakistan. And of course, we would like to take this opportunity to learn about attitudes and responses of patients and providers towards a genetic diagnosis, because without that, we really are flying blind over here. So that's all that we have. And for now, in terms of my presentation, and I would like to stop sharing my screen so that we can see our panelists. And I am going to start this series of questions by giving you a bit of a intro into what we're about to go into, so that we kind of have our ducks in a row, and then we will, of course, jump right into the meat of the action, and we will get started with the questions. I know you're all eagerly waiting for me to stop talking and let the
Aisha, can we add one more thing that after this seminar, we plan to publish this. So everyone, all the panelists should know that we are recording it, and we are planning to publish need assessment type of document somewhere in Pakistan, hopefully, or in US.
Yes, exactly what Dr. Rizwan said. Like I said earlier, one of the main goals of this webinar is to introduce the Pakistani Society of Medical Genetics and review the current status and needs of medical genetic services in Pakistan. Also, we would like to bring to light the amazing work that is currently being done in Karachi by some brilliant, brilliant doctors and brilliant, brilliant patient support groups, and to allow them to share their views on how to build on that foundation and bring it to the masses. So let's get started. I'm going to begin with a not so softball question to Dr. Ahmed. Dr. Ahmed, if you could please unmute yourself. Our question to you is, as one of the very few medical geneticists of Pakistani descent, can you please walk us through some of the motivating factors that led you to consider medical genetics as your specialty? And can you please tell us a little bit about your training in the US? Thank you.
Assalamu alaikum, everyone. Welcome, and hope everyone is staying safe. Can you hear me all?
Yes.
Okay, great. Thank you, Aisha, for the great presentation and introduction. I appreciate it. Before I start, I would like to give you a little bit information about what is clinical genetics and what is medical genetics, because I will be using that interchangeably. The word medical genetics is mostly used as a broad term for all disciplines of genetics, which includes the laboratory genetics, the genetic counseling, and the different facets of clinical genetics. Whereas when I talk about clinical genetics only, that's mostly the work that I do, which is basically seeing patients in the clinic for medical related conditions, which are not biochemical. So just to give you that perspective, that medical genetics is a broader term and clinical genetics is kind of more limited to the clinic itself. Interesting question. So, as most of my Pakistani colleagues who are online would attest that when we were in medical school, most of us used to just omit the genetic chapters. We would just omit them. We would not worry about them because we knew nobody's going to ask us about those genetic questions in our vivas or in our exams. So we, generally would just leave them alone. But, I don't know how it is these days and if things have changed, but I doubt it. So most physicians coming out of medical school in Pakistan have limited knowledge of medical genetics, and we mostly read about it when we are taking our USMLE exams or postgraduate exams. Personally, for me, my first exposure to medical genetics was during my pathology residency training in the United States. And it was actually my teacher and mentor, Dr. Rizwan Naeem, who's our panelist, who actually introduced me to the field of clinical genetics. He sent me to a college meeting, and I just loved it. I was very intrigued and fascinated by this field, especially because it was novel and interesting, and there was a lot of buzz at that time because of the discovery of the Human Genome Project. Um, An opportunity presented itself after completing my pathology training. I was lucky to join University of Miami residency program under the guidance of another world-renowned geneticist, Dr. Herbert Lubbs. And then there was no looking back. And here I am. Um, as Aisha, you said, the field of genetics is not new. I come to think of it. Genetic is the fundamental basis of life and disease. And it is just that our understanding of clinical genetics has greatly increased with the decoding of Human Genome Project. And of course, advancements in genetic testing technology and especially with bioinformatics. Um, because of all these reasons, genetics has now become an integral part of almost all disciplines of medicine. And especially it's rapidly evolving. Especially now with COVID-19 pandemic, I think every layman knows what a RNA virus is, and and PCR has become almost a household term. So genetics has just reached, I think, every household now. Um, as far as training in clinical genetics is concerned, even in the United States, there are very few trained clinical geneticists. To give you an idea, the US population is about 330 million people. And for that, there are only about 1,700 board certified clinical geneticists. And I'm talking about clinical geneticists. And I don't even know how many of them are in the US. Some of them have gone home, and I know Salman is one of them, and he's in Pakistan. Um, and if I can count on my fingers, I can literally count 4 or 5 maybe doctors that I know who are clinical geneticists of Pakistan origin. So there are not too many of the trained clinical geneticists of Pakistani origin. So basically, the trained clinical geneticists are very few, not just around the world, in the United States as well. And the reason for that is, A, it's a new field and not too many people know about it. And secondly, the residency training process to become a clinical geneticist is quite lengthy. It takes about 5 to 6 years to become a clinical geneticist. Um, and over here, it's a little bit more complicated because you have to have another primary specialty before you can enter clinical residency, or enter a combined primary specialty or a genetics a primary specialty combined with the genetics residency. So most clinical geneticists that you will meet are basically double boarded. They have their primary specialty, and then they have already done the genetics residency. So the most combinations that you see are clinical geneticists with internal medicine, clinical geneticists with peds, clinical geneticists with OB, clinical geneticist and neuro, and as in my case, clinical geneticist and pathology. So again, most of those people have double boarded, and it takes a long time, and not too many people are ready to wait that long to start making
So,
money.
so Dr. Ahmed, you mentioned some of the really important things there. I just wanted to say that, I like to think about geneticists like neurosurgeons. There are not very many neurosurgeons out there either, are there? So it really is, difficult, and a select group of people are selected to do this, and it's a competitive and very exciting and place to be in. So that's some of the reasons that Dr. Ahmed mentions, why there are so few geneticists. Now, I would like to take a perspective from a genetic counselor. So, Myla, if you can please unmute yourself. I'm going to ask the next question to Mila. Mila, you have the experience of writing and publishing a peer-reviewed journal article in the status of genetic counseling in Pakistan. Can you please discuss your findings?
Thank you, Aisha, and Assalamu alaikum, everyone. Officially, you heard from me before, but I would like to welcome everyone to this webinar. I will definitely talk about my research findings, but I do briefly want to talk a little bit more about genetic counseling as a profession. Thank you, Dr. Ijaz, for describing more about what medical geneticists are in the US. So as for genetic counselors, it's not as extensive an education process because we are not doctors. So genetic counselors are professionals who have a 2 years master's degree in human genetics and genetic counseling. So currently there are about 50 accredited genetic counseling certification programs, master's degrees programs in the US and 4 in Canada. And together these have graduated around 5,000 genetic counselors that are practicing in North America. And these are certified genetic counselors, so they have passed that certification exam at the end of the 2 years. Most genetic counselors, they work in a clinical or a hospital setting, and they have a specific specialization, such as pediatrics or cancer, cardiovascular, neurology. I myself work in the Department of Pediatrics, but we see both peds and adult patients as well. Regardless of that specialization, just like Aisha mentioned in her presentation, genetic counselors are trained to help people and their families understand their genetic health. So they give information about how conditions are inherited, their prognosis, their recurrence risks, what genetic tests are appropriate at what time for an individual or their family, and what those results mean. So really they're trained in counseling technique and molecular genetics and cytogenetics and so on. So they're able to really communicate in layman's terms on the level of the patient, with the patient and their family about what's going on. So with sort of that background of genetic counselors, I'm going to switch and talk about the research that Aisha initially asked me about. So when I was being trained to be a genetic counselor at the program at Stanford, I had my research study, and just to make a point that all of the programs here require that the students within those 2 years, they do some sort of research study or a thesis, eventually with the goal of that being published in a peer-reviewed journal. So my study was wanting to look at the views of Pakistani medical doctors about whether they think that there is a future for genetic counseling in Pakistan. So what I did is I went back to Karachi, that's where I grew up, that's where I'm from, in the summer, and I distributed surveys to doctors that were practicing both in the private sector and the public sector. And then I would leave them for about 2 weeks and then go and collect the surveys. So the surveys were given to, I would say, about 70 practicing physicians. 50 of them completed the survey, so my N for my study was 50. They were provided different scenarios, and they were asked where they saw was the role of a genetic counselor in those different scenarios. So the results really showed that I truly identified appropriate and accurate roles for genetic counselors. So they saw genetic counselors explaining Down syndrome, for instance, and chromosomes to patients. They saw them talking about BRCA1, BRCA2 genes that are associated with hereditary breast and ovarian cancer syndrome. They saw genetic counselors being able to explain beta thalassemia inheritance to patients. So really apt roles were identified by the respondents in my survey. And overall, it was an overwhelmingly positive response. So all like 100% of the respondents said that if there were more genetics clinics that were available in Karachi, they would definitely refer their patients to these clinics. A lot of the respondents, they did identify that they felt that this is quote unquote a luxury in the Pakistan healthcare system, that there's so much health disparity that this might not be something that's feasible. However, it is definitely something that is needed. So overall, I would say a very positive attitude towards the provision of genetic counseling services as a part of the healthcare system in Pakistan. And I would like to thank anyone in the audience who at that time completed my survey. Thank you for that.
Awesome, awesome. Myla, wow. I mean, the only time that I've ever seen 100% consensus on anything is when we're talking that puppies are cute or something like that. Or I don't know when else we have ever said 100% consensus on anything. Okay, so we've heard from the US perspective, and now let's get to the meat of our discussion here. We want to know about the Pakistani perspective, and I'm gonna ask Dr. Manem to please unmute herself. And my next question is going to be directed towards her regarding prenatal genetic counseling. So Myla just mentioned that, you know, about 100% of OBGYNs wants genetic counseling done. So can you please tell us the current status of prenatal genetic counseling in Pakistan? Thank you.
Thank you very much, Aisha. I hope you can hear me.
Yes.
As Myla has set a very good tone to this, you know that there is no formal genetic counseling available. All the organizations or the hospitals and institutions are working in their own capacity. Like not everybody has a geneticist, but mainly I'll talk about simple things like Down syndrome, thalassemia, cystic fibrosis. They're mainly done by OBGYN consultants, pediatricians, generally OB and pediatricians. And yes, having given the choice, they would refer the patients, because I get a lot of referrals mainly for pre-pregnancy counseling, for previous history of Downs, thalassemia, cystic fibrosis. But in the same scenario as Pakistan, in Punjab, it's a little bit different because they have got a thalassemia program going on. So a lot of people are there geared up to do counseling for thalassemia, screening and diagnosis. So it varies from one place to another. Generally for me, I would see people for pre-pregnancy counseling, as I've already said, or counseling for something that has gone wrong in the ultrasound. They've got an abnormality, found an abnormality in the ultrasound, and they want counseling for. And primarily, and the third thing is that while I'm doing an ultrasound and I find an abnormality, then I would be doing counseling. For example, if I'm doing a nuchal translucency screening ultrasound and I find the big nuchal translucency, then I would do the counseling myself. If this is done by somebody else, I usually get the ultrasound reports and somebody comes for counseling. But generally, if it is with me, I tend to do my own counseling and counsel for invasive or whatever or genetic problems it is. So it varies, but generally, yes, by far, most of the OBGYN consultants would like to refer their patients. And not only this, any previous history of IUD, neonatal deaths, miscarriages, they would like to have to know if this is chromosomal or it is genetic. So basically, I don't know if I can give any more examples, but I see a lot of patients being referred for early fetal growth restriction because the OBGYN people are all very aware. You know, it was not there in 20 years ago when I started my subspecialty. Now people, as soon as they encounter early fetal growth restriction, they think of a genetic problem and they would just refer the patient not only for the ultrasound, but for the counseling. But I hope this answers your question.
No, brilliant. That was exactly what we were looking for, Dr. Manan. Thank you so much. I would like to switch our focus to pediatrics and general genetics at this point. Dr. Kirmani, could you please unmute yourself, because I will be asking the next question to Dr. Kirmani. Given that you are one of the few officially trained geneticists in Pakistan, can you please tell us about the current genetic service structure in Pakistan, officially as well as unofficially, please?
Thank you very much, Aisha, and thanks to everyone who's taken out their time to come to listen to us. This is obviously a very, very important topic. Everyone realizes that not only people from pediatric backgrounds, but all over, as was mentioned earlier. So, the issue with Pakistan in general is that we are a country of contrasts. and huge disparities exist within our healthcare systems. And there are massive differences between what is available in the private sector and what you can offer patients and what is available in the public sector. And I think one must be cognizant to those disparities. The patient pay mechanism is mostly cash, out-of-pocket payments, and that makes it hugely difficult for people to afford even a consultation fee, let alone expensive genetic testing. So I think in that background, to offer solutions or counseling in a field of genetics where the treatments or management are not tangible to the families, as well as the fact that a lot of times you just have prevention to offer for future pregnancies, and mainly just palliative care for the current care of a lot of disorders such as the leukodystrophies, for example, or the storage disorders that we see. So I think hugely challenging, and I think people well before me, who were practicing in pediatrics or OBGYN, know these challenges and continue to face them. Mm-hmm. So I think as we move ahead, we must acknowledge as a group what we need to do. And I'm so glad that we've sort of been brought under one banner to try to do this in an organized fashion, because I think what's happening right now is little pockets, little institutions doing a little bit on their own. And I think a concerted effort is now needed to bring people together. So I think clearly, to answer your question, number one, there is clearly a need. And the need is being felt by patients and families, because we have a number of referrals directly from patients and families, not from physicians. But we have an equal number of referrals from a diverse group of physicians, whether they're obstetricians, gynecologists, pediatricians, general physicians, family practice doctors. So I think because we're a huge, huge country with a huge population, a huge birth rate, lots of consanguinity, the need is clearly there. So I think, I hope we can inspire some young people to take on the challenge of, doing clinical work, doing research in the background, doing laboratory genetics, doing clinical genetics, lots of opportunities over there. Now, in terms of differences between what's happening officially and unofficially, there are issues, and I think Dr. Jamal, for example, is here. He's trying to do a lot in the government sector, despite all the challenges, all the funding issues, and the fact that the patient population that him and his team are asked to see really cannot afford even very, very simple things which may seem affordable to others. Myself and my team work at the Aga Khan University, which is a private university. Over there, we do see a lot of unaffording patients, but a number of them can at least pay the consultation fee, and then we can try to figure out creative ways to subsidize them. So I think the summary of what I've experienced over the last 5 to 6 years is that if we can provide affordability, number one, and accessibility, number two, and both are intertwined, because sometimes just the mere act of traveling from upcountry down to Karachi, for example, can just exhaust the family's resources. So we must try to provide a telehealth issue to a number of genetics problems that are existing in remote parts of the country. And we must provide testing and then further management in an affordable fashion. I think if we can try to head in that direction, we would have at least begun to address the problem. So I hope that answers your question.
Definitely, that was so well put, Dr. Kirmani. I would like to ask my next question to Dr. Raza, because you mentioned him in your response. So Dr. Raza, if you could please unmute yourself. My question is really twofold. I think Dr. Kirmani alluded towards it, a little bit of it. I wanted to get your perspective on the public versus private sector, because obviously you have a lot of experience working with the public sector. So I wanted to get your take on that. And also, you know, we have been conducting the telegenetics clinic at the NICH for a few months now. And so far, I wanted to know what has been your experience like from the patient's perspective, and also what are the thoughts from the providers that you have heard so far. So Dr. Raza, please unmute yourself. Thank you.
Thank you. Thank you for giving me the opportunity, and thank you everybody for being in the session, which Salman said is extremely important. I would pick up a couple of words that have been mentioned earlier in the talks. Salman has used the word disparity, and Maila has talked about in her survey that medical genetics or genetic counseling is a luxury. That actually summarizes the whole situation right now, because on one hand, we have a huge disparity between the affordable and the non-affordable. And that kind of puts the whole thing about the use of medical genetics and the use of genetic counselors as being a luxury. It's not. I mean, it's the same discussion that we had years ago when, you know, even you can compare that, you know, if children are dying from diarrhea, why do you need to bring in expensive things like MRI or CT scan when you it's from dying? So these are things and shouldn't. So the question of luxury is on certainly true. On the other hand, look at it from the perspective of you know, somebody who is here with a child with Apert syndrome. And I mean, so if you look at the individual family, they have all kinds of disorders in this social background. And for them, it's not a luxury, it's a necessity for their child to have an access for some kind of a counseling session or some kind of an understanding of the disease or some kind of a support. Even in this society is an absolute must. Now, what is available is a very sad thing, because this is something, a completely naive area, and there are hardly any trained people around. So, I mean, of course, talking about this kind of a facility being available is in public sector is out of question. But even in the private sector, I mean, even if you have somebody affordable, you don't have anybody to refer to. And currently, as Dr. Muneem has mentioned, that pediatricians and obstetricians have traditionally been filling in for this role of explaining to their patients about the kind of the disease that they have and offer some kind of a formal, informal genetic counseling to the parents for the disease and the future outcomes and all that. But of course, we do not have the expertise to provide all these details, and neither do we have the time and the other facility available in our hand in a busy clinical setting to do the role of the genetic counseling. Mm-hmm. So clearly we felt that there is a great need and a great demand for such a service being available, first of all, in this setup, in this country, city, and everywhere. And then once the facility become available, even if in the private sector, then we need to expand on it. And of course, you know, make sure that the service is, some kind of a service is being provided, not just in the private sector, but also in the public sector, which drains the bulk of the population, as well as the kind of population that do not have the resources to go and seek that kind of an advice, treatment, counseling, and further exploration for their child's disease in the private sector. So that was the kind of a background that I wanted to touch upon regarding the service itself. Regarding the clinic at NICH, we have been talking about this between me, Rizwan, and Ejaz to begin with since the summer, as you mentioned, but it's kind of a very recent thing. And we've only started somewhere around in September, you know, a couple of months ago, really. And so far, we have been able to have at least 7 clinics at NICH. And I think they have been very fascinating, very thought-provoking, very positive, because the feedback that we have been getting from the parents, and they have thoroughly enjoyed the attention, the explanation, the atmosphere where they had the opportunity to talk to the professionals about their child's disease, there to ask the question that they have been wanting to ask, and get a better explanation on that. So it has been a very, very positive response, and it has been very encouraging that what we thought initially about, we had a kind of a dream that we have to start something like this. So it's like a dream come true in some ways. And of course, this is just the first step, or this is just the beginning where we have many miles to go from here. Thank you.
Beautifully put. Thank you so much, Dr. Raza. I could say on behalf of our team here that we've thoroughly enjoyed providing genetic counseling to your patient population at NICH. I would like to switch gears to the laboratory end of things for needs assessment, it's the current status. Could I ask Dr. Rizwan please to unmute himself? Dr. Rizwan, you are among the few genetics experts who helped establish a cytogenetics lab in the public sector at NICH in 2007. Can you please tell us a bit about that experience and what testing is currently available through that lab? Please limit your response to 4 minutes. Thank you.
Definitely. So in 2005 and 6, when we were visiting, we usually visit Pakistan every year for any reason or no reason. And we realized, to be honest, NICH, Dr. Jamal Raza is a classmate also and a dear friend. And when we were visiting NICH, we saw kids with ALL, acute lymphoblastic leukemia. And we know at that time I was working at Texas Children's Hospital in Boston, in Houston. So we know that the survival rate for ALL is over 95% in West. And when we looked at the data at Child Aid Association at NICH, the survival rate was not even 20 and 30%. And the reason was very simple. And the reason was that if you have ALL, if you define ALL by risk category, it's low risk, medium risk, or standard risk, or high risk, then you can modify your treatment accordingly, and patients get better treatment. At that time at NICH, they were just doing a shotgun type of approach that everyone is treated with leukemia, just knowing about with the age or with the white blood cell counts and so on. So we thought that is a need of that time. And with Child Aid Association, with my classmates from across the US and world, and with an organization called APNA. And we also wrote a grant to a Rotary Foundation, matching grant. And we were able to collect a decent amount of money to develop from scratch a cytogenetics lab. And we were talking about 2007 and 8. So that was just the start of focus was to treat these young adults, young kids who have leukemia. And as majority of kids have ALL, and if they are classified accordingly, they can be treated accordingly. And CAA has a data that how many kids have been surviving now, and it's just amazing. So this is the passion at that time. And with you and many others, we have more passionate people around, and hope we can, I will go back to that discussion, and I know you and me have talked multiple times about it, reducing the disease burden of society, right? So if you do a good screening test, you can at least inform people to make an informed decision, and then can help reduce the disease burden. So that's my answer to that brief thing we have done so far.
That is so brilliant, Dr. Rizwan. I cannot emphasize on the need for doctors and genetic counselors like yourself that are going to take these initiatives. Even if it's a baby step, it goes a long, long way. And we're very appreciative of you helping us out. Okay, so Dr. Hassan, I would like to direct the next few questions to you. So if you could please unmute yourself. Tell us what are the top 5 tests that are being ordered through your laboratory at Aga Khan, and how much testing is being done in the public versus the private sector. We got some sense of it from a doctor and physician perspective. I wanted to get an idea from the lab perspective, please, and thank you.
Thank you. Assalamu alaikum, everyone. Thank you, Aisha, and thank you, Dr. Rizwan, for inviting me as part of this panel. And it is really important to see that the laboratory diagnostics, which I'm involved in, is actually one part of the whole process. Because you mentioned the patients need to be talked to, screened, counseled to come to testing. And we have a system where patients are referred to us from a few, mostly from a limited number of doctors, people like Dr. Jamal Raza, Dr. Salman Kirmani. We have doctors from Lahore, from Islamabad, and certain cities that are referring tests to us. But primarily our tests are for thalassemia across the board, thalassemia and dystrophy testing. We test for beta thalassemia mostly. We also test for alpha thalassemia. Amongst the dystrophy testing, we do testing for SMA, focusing on SMN1 and SMN2 genes, where we look at deletions in both exons. And we do testing for Duchenne muscular dystrophy. And that the frequency of these tests, just to give you an idea, is about, we get about 7 tests for each of these each week. So about 20 to 30 cases, out of which a predominant number are positive. And the tests, if one looks at the clinical history that's provided with the patients, it is evident that often the cases that come are not cases from families who have had their first child tested, but it's often there's an affected sibling, or there's some family history. And what always comes to my mind as I sign out these tests is that had these people had more awareness, or perhaps been guided better, then the situation could have been avoided, because you have people like Dr. Shama, who are a limited subset of people doing the prenatal testing. And then, the general awareness is really, there's a lot of room for improvement. You asked about additional tests. So there's the thalassemia, there's the dystrophy testing. We do cystic fibrosis testing to a limited extent. And then we do karyotyping. So a lot of karyotyping, chromosomal typing for both amniotic fluid and CVS we get. We do, Dr. Rizwan mentioned testing for leukemias. That is actually the bulk of our karyotyping. We do about 100 to 150 of those each month for leukemia testing. So that's pretty much the bulk. And even in the private and public sector, most of the genetic tests is focused on thalassemia testing. Because the private labs that are doing it elsewhere are doing thalassemia testing, focusing on beta globin, common mutations. So that's another aspect that I'd like to bring up here, that as our knowledge of medical genetics has grown, the diagnostics has also improved. So a lot of the testing across the board in Pakistan is related to single mutation, single gene-based testing. So for example, in the beta globin gene, ARMS PCR is used that looks at a certain panel of mutations, but that may not pick up other mutations across the whole gene, silent mutations. So at the AKU, I think we're perhaps one of 2 labs in the country that I know of that are using sequencing of the globin gene to do testing. So in the paradigm of expanding diagnostics, it's a multi-level thing to understand. What gene do you want to look at? What is the capacity of the laboratory? Is it best to do the simple most common mutations first, so at least that can be used as a screen. And then, how much further comprehensive testing can be offered for each disease. So there are many things that need to be considered. And of course, as Dr. Jamal Raza mentioned, the laboratory testing is quite limited, as already been discussed. It's both awareness and just healthcare access. This is all part of that paradigm of access, both to physicians who can provide the correct advice and, of course, the support, financial support for the testing.
Thank you so much for those insights into your work every day. It really, is a stark contrast with the ease of genetic counseling and genetic testing that we have over here, and how we don't bat an eyelash when we're ordering tests, and to see the contrast is quite something. I would like to ask Rabia to please unmute herself, because I will be directing the next few questions towards you. So Rabia, thank you for joining us. And please tell us about what have you been doing as a patient advocate in Pakistan? Please take it away.
Thank you so much, Myla and Aisha, for allowing me to be a part of this fantastic forum right now. So my name is Rabia Aziz, and I am the founder of Special Needs Pakistan, which was founded in 2013 after the birth of my daughter, Alia, who was born with Apert syndrome. And I am one of those, I would say, I felt educated, privileged individuals, who go by the book for parenting. And then came along, I was literally in the last week of my final trimester. And the sonologist told me that there's some facial embossing going on with the baby's face, and things are not looking like they were a few weeks ago. That was my first encounter to some kind of counseling. There was the only kind of counseling which was available was when the gynae was actually talking to me about risks, and I'm having a child at 30, and what my husband and I might have in comparison or in connection or in similarity. And we had gone through those NT scans and many scans, but what was missing was somebody telling me, or a genetic counselor or a family counselor telling me that what are the risks involved. And keeping in mind, I am not in a part of a cousin marriage, which is the first question which was asked when my daughter was born after an emergency C-section. And she was born with Apert syndrome, but she had fingers missing, and she had a huge part of her cranial, premature fusion of her bones in her cranial. And I was very fortunate that I had doctors like Salman Kirmani and Dr. Babar Hassan, who were available to me at Aga Khan. Other than that, there was tremendous chaos. And that tremendous chaos actually led me to construct this support group for parents, where they could understand and know what all they can avail, so that they're not in the dark. Because unfortunately, as it's done in the West, we don't have everything under one umbrella. We do have the means and the services, but not all the doctors are holding hands and are accessible and available to the patient body, to the patients, to be able to explain to them. And in 2013, when I had to face doctors telling me, well, why didn't you have this child aborted? That was a red flag. So the etiquettes, the mode of communication, and how to sort of bridge that gap between a patient, a child who might need more than just counseling. What are the next few steps that need to be rolling out? What needs to be done? What needs to be detected, diagnosed, tested? And like I said, I was fortunate that I had at that point in time a geneticist available. So he wrote those tests down. I got those tests done, not everybody could have afforded those tests in that capacity. And so as a patient advocate since the last 8 years now, when I see, or when I am met with parents who might have the firstborn who is a specially able child, or who has some kind of a lacking, we tell them that, listen, as your support group advisor, or as your support group mentor, I would, tell you to get genetically tested. So either you or your husband need to go in for genetic testing. You need to meet with a genetic counselor or a geneticist who can advise you further, because if you continue to have another child, you are putting yourself and the child at risk. And these are by and large the risks which gynaes are telling us about, right? Where the OBGYN is telling you that these are the risks that you're exposed to. So as a patient advocate, I've been fortunate enough to be able to talk at the patient level, because they know that, okay, Rabia has Alia, and they've walked this unknowing chaotic journey where they had to kind of like gather all the information for themselves. And so now if they're saying, okay, you need to get your harmony testing done, we need to figure out where harmony is available, or where what we can do to get ourselves tested. Can we get ourselves tested? Is somebody going to fund the testing? Can we, is the welfare program at AKU, will that pay for the testing? So these are all the kind of questions we kind of narrow down and help all the people who are on the group. And Aisha, thank you for introducing the group Special Needs Pakistan. At this point in time, we are 14,000 plus families on this particular group who have helped each other and helped people who are in the similar situation, of not being carried away by misinformation, because misinformation is one of the main things that we are looking at right now over here. If I was told 8 years ago that Apert syndrome cannot be diagnosed with the baby when the fetus is in the womb, that was misinformation for me, even though I had all my ultrasounds done. So what was missing? What was the disconnect? Was Alia one of the only ones? Why is there no data collection? Why is there no data collection for all the genetic counseling being done, or all the genetic testing being done? If there were 8 Apert babies who were born in the last 13 or 15 years, there was no accessibility for me to find out, or to be able to ask them what kind of information, or what kind of journey am I going to be treading upon. And even in 2016, when I actually had my third baby, there was only a few OBGYNs who were willing to list down all the risks for me. Even at that point, genetic counseling was not widely available. So we're just talking about 4 years ago. And even 4 years ago, Harmony had just been introduced very, very early on into the hospitals. So these are the kind of things and information and informative material that we are trying to bridge and bring a connectivity between medical practitioners and the layman, or the families who are going to be going through that journey. So I hope this kind of concisely answers your question.
Oh, so brilliantly. Thank you, Rabia, from the bottom of all of our hearts, for doing the hard work that you do. Really, none of us can do this. None of us in our individual capacity can talk to patients at the patient level, and your role is so irreplaceable that I have tremendous gratitude towards what you do. You mentioned so many things. I'm gonna just pick up on one to lead on our next panelist to answer a question. Dr. Maneem, can you please unmute yourself? I'm gonna just pick up on something that Rabia had said. Rabia said that gynecologists are the ones that are doing counseling. From that perspective, and from your unique perspective of being the only trained, fellowship trained diplomat who can offer genetic counseling to patients. Can you please give us some idea on why you think genetic counseling is so important in the prenatal setting in Pakistan, specifically prenatally? Thank you.
Thank you very much, Aisha. It's a very relevant question. And the important thing is that in Pakistan, there is a high rate of consanguinity, and that is why it is important that there is a high prevalence of genetic conditions, that we have genetic counselors in place, because it makes a lot of our life a little bit easy, because we have somebody who can work out, have a detailed history, give the risks, and then give them the options to the parents if there is a prenatal testing available. So all these things are important, and I think that the genetic counselors play an important key role, that they can work side by side with us and the geneticists to in counseling the parents and to assess the risk of a condition and decide what options the couple has available. And also, I would like to touch upon something that Rabia said, that affordability remains a big issue in Pakistan. So I think not only is counseling important, but accessibility to testing. Zara has spoken about thalassemia screening and testing, but thalassemia, the type of sort of a hi-fi testing it's not affordable for many people, because of the sheer cost of thalassemia, CVS, and prenatal diagnosis comes to around 40,000 rupees, which is not very in the range of most of the middle class people. Thank you.
Thank you, Dr. Manim. Dr. Raza, can you please unmute yourself? For the sake of time, I'm going to start the rapid firing some of the questions. Dr. Raza, if you could please tell us, ideally, in terms of needs assessments, what are your goals for genetic services at NICH?
Thank you. I'll be a little brief because I think there's a lot of questions that are still pending. I think the first and the foremost goal of setting up something like this is to provide the service of genetic counseling to patients who were, because the service was non-existent, and patient at the public sector we felt was in desperate need of such a service, especially if you can provide it from the highest professional level. So that would be a great service, and end of the day, I think that is the best that we can do. Secondly, we also want to expose our physicians and who are already consultants, like pediatricians, and also the budding trainees, to the field of this clinical geneticist and genetic counselor. And they have little idea, because as Ijaz initially said, still I think there's a great dearth of clinical applicable knowledge in the field of medicine, especially when they are going through their undergraduate training or even their postgraduate training. The exposure and the real nature of the clinical geneticist and the value is not really well appreciated. So we want to, as part of that, we want to expose our medical fraternity with that kind of field. Then we also want to establish, as we have already pointed out, that we have identified Ms. Bahani, who is one of our very star trainee, as to have some kind of a training for genetic counselor. But she, of course, is not going to be the only one. We want to really utilize this service. This is, of course, just a beginning, but through NICH, we want to utilize, and through with your support and services, we want to have a collaborative effort to develop some kind of a structured training program which have a certificate or a diploma at the end of the training, so that we can produce different level of clinical geneticists, clinical geneticists, at least genetic counselors, who can provide some kind of advice at different level, especially at the public sector where it is most needed. Then we want to, of course, expand the general awareness about the need for this kind of service in among pediatricians and among common people. I mean, as mentioned that sorry, Aisha mentioned that the name of the lady with Apert syndrome.
Rabia.
Rabia, sorry. The Rabia mentioned that she's, one of the very fortunate ones, that she's at least aware, she's educated, she has the at least the right kind of questions with her. A lot of people in our community don't even have those kind of questions. They don't even know if such a thing exists. So it's also important for the general awareness of the general public. And she's doing a wonderful effort, I must appreciate, of putting together 14,000 families, which is not an easy task in itself. But of course, the general people also need to know that such a thing exists where they can fall back on if they need. And then, as Salman also mentioned, that we need to now moving towards the clinical side to the lab, that we now need to also develop some kind of a genetic lab-based facility at locally at an ICH, maybe at AKU and other places, and have some kind of an integration where we avoid duplication, but we have a service which is available and affordable for the patients, and also sustainable. I mean, a lot of time, we develop these kind of a service, but they are not sustainable because they are not cost effective. So we need to think long term and develop some kind of a service which is affordable and which is also sustainable. And of course, in the meantime, we are also collaborating with you and to see wherever these tests are available in the rest of the world, so that we do not have to reinvent the wheel ourselves all the time, but we can also use the expertise which is available elsewhere in the world, and ship our samples and get the results back. So there's a lot to be done, of course, and this is just the beginning. And I think NICH, being the premier children's hospital, provides an excellent platform to begin all this journey.
Wonderful. Thank you, Dr. Raza. Dr. Hassan, if you could please unmute yourself. As the president of Association of Molecular Pathologists of Pakistan, what or how do you think that AMPP can help promote genetic testing services in Pakistan?
I think there's a tremendous opportunity that AMPP could work with Pakistan Society of Medical Genetics that you have now founded. AMPP is, within the remit of the Pakistan Association of Pathologists, or PAP, and it is one of the 5 societies. And we're new. I see a couple of our members are online. It's very nice to see that they are here. And we have been actively involved in the annual conferences in PAP. And the focus has been on genetics, genetic testing. But certainly by collaborating with genetic counseling, that is one part of the process that was missing. What is the lead up to advising testing? And in addition to the laboratory diagnostics, it would be very useful and I think very powerful that we could plan webinars in conjunction with Genetic Society and help expand the scope through the AMPP as well. So I'm looking forward to that.
Great. As are we. Thank you. Dr. Rizwan, if you can please unmute yourself. How can genetic testing services be made widely available to the patient population in Pakistan in the public sector? And why do you think it's important that masses can utilize genetic testing? Dr. Rizwan, you're not mute. You're still on mute.
Sorry. So what I wanted to say that AMPP, when we had first meeting in 2016, if I'm correct, at PC, where we brought in Association of Molecular Pathology USA to a PAP meeting, and Zara and Natasha and many other pathologists are very adamant part of it. So this was the thought that as you mentioned very earlier, there are two ends of genetics, a front end and the back end. And back end is as much important as the front end. And AMPP's goal was to start teaching and training. We did many workshops at that meeting, fish workshop, sequencing workshop, genotyping workshop, and so on and so on. So I think the AMPP's work really is to be a resource to let these technology develop at different hospitals like NICH, like Children's Hospital in Lahore. Dr. Saqib is online. He has done a phenomenal work in Lahore. So that was the goal. But unless we have a funding available for these things, nothing will happen. And yes, we can provide resources, we can provide expertise, which we've been doing for many years and continue to do that via AMPP or via Society of Medical Genetics. But in the end, we need to come up with a model, as Dr. Raza said, that how to make it affordable. The model we have adopted at NICH was this, that whenever there is a patient from NICH, there'll be no cost to it. But if there's a patient coming from outside NICH, many private hospitals in Karachi, we will charge for that. So that covers some part of the expenses, if not all the expenses. But that is the model we need to work with. And there are many good public sector labs and universities in Pakistan, which we can work with to provide low cost services or at no cost services for the patients in need. And I will just end with one read, which was in a Dawn paper recently. It was dawn of 2/22/22. There was a conference in Lahore, and one of the speakers said, Professor Homa, the genetic diseases are in most cases serious, chronic, debilitating, and life-threatening, often requires long and specialized treatment. And then largely neglected genetic diseases are responsible for 50% of death in Pakistan before the age of 1 year in Pakistan, responsible for significant handicap in older children who have muscular or CNS diseases. So these are the realistic, after infectious disease and malnutrition, genetic diseases are the biggest cause of morbidity and mortality in children in Pakistan. A very high prevalence of inherited or genetic diseases in children due to consanguinity, and so on and so on. So these are the facts. Genetic is not a boutique type of treatment. It is a front end treatment which requires, which can lower the disease burden in Pakistan. And we all, unfortunately, I would say the governments of last 50 years have failed to provide resources for the population for screening studies, for HPV studies, where we have, West has seen that if you just do a simple test of HPV virus detection, you can detect this cancer in women much earlier. And that is not done at national level in Pakistan. Now the prenatal screening for muscular dystrophy, SMA, for Fragile X, and for cystic fibrosis can reduce the disease burden. For example, newborn screening for metabolic diseases can reduce the disease burden. So these are the fundamental things. And again, NGOs and public places and charity organizations are just do a very little part of it, unless there is a support from government sector that yes, they will consider the second most or third most cause of death in children to be a priority. Not much can we do. We can educate, we can train, I see a lot of collaboration already spanning out from this. Aga Khan is gracious to say that if you start a genetic training program, they'll be happy to train someone and shadow someone. Same thing as Dr. Raza is saying, that they are willing to put their resources to develop that existing lab into a next level of the lab, and so on and so on. We have so many talented and dedicated people in this conference. I see that if we need to, this is just a start, as someone has said. This is just a start. We need to subgroup ourselves into prenatal screening, into cancer screening, into different dysmorphology type of screening, and so on, and then have a group available for that resource to develop. I think this is genetics, and I will end with this, that Dr. Ramsey Cotran, who has written a famous book in pathology, when I was a fellow at Harvard at Brigham and Women's, his office says that when I was a student, I thought genetic is a boutique subject which interests me and I wanted to study. And now I believe that medicine is a part of genetic. No subspecialty of medicine is beyond genetics, or genetic is not contributing towards that. So that is the reality. And we as a group, we move forward, we form this organization. I would like each and every one to become part of it. And there is no fees involved. We just collecting some data, and then we will publish on these. I also see Dr. Saghira Malik from England, who contacted us recently. She's raising hand, and she has done this counseling for 20 years in Pakistan, one way or the other. If time permits, we should give her a few minutes to speak. And that said, that this is just a start. There is no plan at present. We are assessing the need, and we will move forward with all of you, inshallah.
Thank you, Dr. Rizwan. Mila, if you could please unmute yourself. Dr. Rizwan mentioned that genetic diseases are a huge concern in Pakistan for children. And I imagine that it probably is higher than the third category, the third level, because of how underdiagnosed it is. And so it really helps us understand the very specific needs. Can you please tell us, in your experience, with the education of medical students and genetic counseling students in Houston, shed some light on where you see genetic counseling training in the future of Pakistan? Where can we have the most impact? Thank you.
Thank you, Aisha. That's an excellent question. And I see that a lot of people in the chat have also made comments on what the genetic counseling training can look like in Pakistan. And honestly, I won't pretend that I have the answers and I know exactly what it should look like, or that I know best. However, this forum of people like Dr. Rizwan just mentioned, we have all the experts here. We have all of the people here who are really interested in starting genetic counseling program in Karachi. So I hope that putting all of our minds together, we're able to come up with something. However, I do think that at least in the beginning, I don't think it's going to look exactly like what it does in the US or in North America. We might need to do it in a different form where it's a certification course, or not as long as a master's program, a shorter certification course. I see that people have mentioned in the comments that NICH can be involved. Dr. Kirmani mentioned in response to a question that said that in typical genetic counseling programs in the US, there are rotations where students observe and then do cases on by themselves in the main fields, prenatal cancer and pediatrics or medical genetics. Dr. Kimani mentioned that it is possible that they could observe at his genetics clinic. Also, with this whole advent of telehealth, COVID has kind of forced us to really take upon ourselves to use technology more and do telemedicine more and do online education more. Like, I'm sure a lot of us in some way have participated in education. My kids are doing school online. Rabia's kids are doing school online. So we can really use that as much as possible. So I would say telemedicine, online training, maybe shorter courses, maybe courses specified towards certain specialties. So like it's already been mentioned at this conference many times, that there are a lot of people providing genetic counseling, right? There are physicians providing it, there are nurses providing it in the thalassemia field, in the OB-GYN field, everywhere there are doctors providing it. But just to have a course for medical professionals in a certain field. For instance, if they are OB-GYNs or they're nurses who want to be more specialized in providing preconception and prenatal counseling, then we can have maybe a certification course that focuses on everything but specializes on prenatal. And then they are educated to do that, or they have the skills rather to be able to do that in that setting. So really there's a lot of things to be thought about. There was a question in the chat that says, can the board that certifies or accredits programs in the US accredit a program in Pakistan? You know, that's a great question. From my basic knowledge of working with the ABGC, which is the American Board of Genetic Counseling, that here in the US, I don't think currently that is a possibility. However, that's you know, something that we could look into and discuss more.
That's so great. I'm so happy that you're manning the womaning the chat box, because this is so fantastic, because a lot of the great ideas are actually coming from there. I really hope that we can utilize a lot of that, even though we don't have the time to go through all of those questions. Please touch very briefly, take 30 seconds to bring light to the cultural competency aspect of genetic counseling, please, Myla.
Sure. So the cultural competency really is to be able to train an individual who can then provide counseling or provide education to their patients, irrespective of any cultural barriers, right? So here in the US, in these genetic counseling programs, we are all trained to be culturally competent. We are educated about the cultures of different groups, different ethnicities, different religions, different socioeconomic levels, so that we are able to cross that barrier and we can communicate with our patients appropriately. In Pakistan, it is important for us to have local training so that we can produce culturally competent and culturally sensitive genetic counselors. This also came up in the chat, who are familiar with the culture, tradition, religion, and who can connect with their patients on all of these levels, maybe even speak the same language. So was that 30 seconds?
Excellent. I think a couple of times we have said, you know, rates of consanguinity is high and all that stuff. I really want us to focus on destigmatizing that. There are masses and masses of people that may want to come to a genetic counselor and seek genetic counseling, but would be intimidated if all they will hear is that consanguineous marriage is the reason why you have this, which is not always going to be the case. We all know that. And so for us to bring light to that, I think is very important. And you said it so aptly. Dr. Kirmani, can you please unmute yourself? I wanted to ask you, what do you think is needed if I gave you Aladdin ka Charag today and I said, please rub the lamp and tell me, what are the 3 wishes that you have that I will grant you? Imagine me being the genie if you can. Then, you know, what is needed? What can you tell me to start a genetic counseling training program tomorrow?
Oh boy. All right. We're never going to stop this conference because it's
and also limit your response to 3 minutes or less. Thank you.
I'm going to limit the scope of your question to genetic counseling. Let's focus on that. Because I think that's something that we can all you know, focus on. So I'm very fortunate to be part of training and then, you know, basically letting loose the first genetic counselor in Pakistan. And Fiza, if you're there, can you please just you know, show your video and just wave. Now again, Fiza is not a certified genetic counselor, but she has been working with me for now close to 2 years. She came with a background in a master's in genomic medicine from Manchester, and, you know, initially applied for a research job. And I'm a clinician, I'm a clinical geneticist, and I said, you know, I need help in the clinic, and I think we can do a lot of work together, and a lot of research will stem from the work that we do in the clinic. And she was on board, and she had exposure to genetic counseling in her courses over there. And so she came on board, and we've been working together now for, I said, around 2 years. We designed a course for her where she was able to get all the clinical exposure that she needed in all the different areas, made case logs. You know, she observed how I was doing things. Now, again, the big disclaimer here is I am not a genetic counselor. Now, I was fortunate for being at Mayo Clinic for 13 years, and I learned from some of the best genetic counselors in the world. And so what I know about genetic counseling is from them. And so I was able to kind of embody those principles and demonstrate them to Fiza. At the same time, Fiza was very diligent and wanted to get formal training as well. So she's currently enrolled in a program offered by the University of British Columbia that includes genomics and genetic counseling. So she will, in the end, get certification for that too. So, but you know, so she's the first one, and she's obviously not going to be the only one. So how do we move forward? So we need people like her, and you know, people like Mispa, who I have just heard about, and there may be others who are doing this, but want to dedicate their future to being a counselor, And again, I'd like to really say out loud, a counselor is not an assistant to a geneticist. A counselor is not an assistant to any other physician. They are providers in their own realm. They advocate for patients. They advocate for the rights and the privileges that are there for individuals with genetic conditions. So I think that's the kind of group we need. We need a critical mass of people who then work with people like Myla and Aisha, who've gone through the formal training process, the rigorous process, and are out in practice. And I think then, to me, the geneticists, both in the clinic and in the lab, are going to assist these individuals in coming up with a program to figure out how we do this. For every clinic that, and when I say clinic, I mean every specialty. So for every specialty, like OBGYN or pediatrics or cancer clinic, I think we need 3 or 4 genetic counselors because it's very, very complex. Every lab, so the biochemical lab, the cytogenetics lab, the molecular lab will require 3 to 4 genetic counselors just to get the clinical information from the people who come in the lab who don't have the clinical care at that particular institution. So I think that's what's needed. Ultimately, we will get to certification. But I don't think we should start with certification as a priority, because then I think we'll be putting the cart before the horse. The need is so much that we need to kind of go through this together, be flexible, learn from all the models in different parts of the world. There is great value in doing things formally and getting certification. But I think the first few people that come out over the next few years will not be certified. They'll have to be grandfathered in, as the term is used, for a lot of things that are done for the first time in many, many countries. And I think taking that model forward, we'll be able to do that. I think there are a lot of professionals, nurses, doctors, even people from biology backgrounds who've got minors in psychology, who would be perfect to kind of go down this road. And I think that's what's needed. So I think for me, I would much rather train 4 genetic counselors than 1 geneticist. I think the impact of 4 genetic counselors will be much more than of a single geneticist, because I think the medical care can be provided by the specialist, the OBGYN, the oncologist, the neurologist, etc. But it's the genetic counselor that actually plays a very critical role. And I think the one thing that's missing in all of our discussions so far is actually how to teach caregivers interpretation of genetic test results. It can be hugely dangerous if you misinterpret test results. And actually you can go completely wrong and completely misguide a family and then make them go down a track. And I think genetic testing is so complex that even people who are in the field have to spend an inordinate amount of time in interpreting things. So I think we need to invest in people who help interpret genetic test results in the background, so the lab people and so forth. And so that when the counselor gets the result, when the clinician with the genetic background gets the result, it's made easy for them. They can access the literature. Some of the stuff is already done for them, and then they go forward. I think those are the 2 things I would strongly advocate for.
Wishes granted, Dr. Kirmani. Next, Rabia, please unmute yourself. As a parent of a child with genetic condition, and please, on the same line of thoughts that Dr. Kirmani had just mentioned, and of course your own experience, tell us, how would you say medical genetic services can help the members of your support group?
Thank you, Aisha. So I'll quickly say that Dr. Raza said awareness, Dr. Shama said screenings, and then Dr. Kirmani, I'll just say non-judgmental advocacy. For caregivers to be able to understand what they're dealing with, how they're going to go through, is just detrimental. It is so, so important, as he pointed out. Secondly, screenings. Not just prenatal screenings. We're still fighting over here to get newborns screened for hearing and vision. So to be able to sort of tell families, because it is a collective, like you said, cultural, it is a familial party. When a lady is prenatally expecting, it's a family party, and to be able to invite the entire family to be able to understand the process is so crucial. And then And then firstly, and most importantly, awareness. The more we talk about it, the more we are reducing stigma, the more we are reducing taboo. Because from in the last 6 to 7 years, what have we seen in Pakistan? Or if I were to just close it in on Karachi, we have seen more families with children with any kind of disabilities, and we can keep giving them all kinds of terms. We can say child cancer patients. A lot has happened. People have started coming out of the closet and coming out into the open. So there is so much more at stake now because people are wanting to become more aware and learn more. There is this hunger to understand, okay, I have been told that my child is a baby born with muscular dystrophy. What are the avenues available for him? What can be done for him? Is it the same streamlined thing which is a case study mentioned on Google, or can my child do better? So that is what we are looking for: advocacy for and exactly like Dr. Kamani said, if we have more counselors available, they'll be able to give them more case studies, more information and valid accounted for information. For example, in 2013, Alia was the only Apert syndrome child that the Khan resident body had seen in the plastic surgery ward. And those 8 students were looking at her in awe as if they had seen something out of a textbook. So what we are talking about is changing the narrative, not just from the medical practice perspective, but from a combined perspective of how the counselors are going to go in hand with the caregivers, with the lab technicians, and then to the specialists. So it is an amazing network that we can build and grow together.
Thank you. Robert, please stay unmuted for a little bit longer. My next question to you is to you as well. I wanted to ask you, in terms of attitudes towards or responses to hereditary or genetic diseases, in at least focus on your members, group members only, what are some of the attitudes, what are some of the responses that you see?
So again, Aisha, stigma, taboo, and that cultural defiance is the top thing that we fight against, right? I had the privilege of having a brief conversation with you where I told you about a child that a family of a harlequin ichthyosis baby that I had counseled at Lady Dufferin. And so being a part of Special Needs Pakistan, I've been honored to be acquainted with a lot of specialists and a lot of midwives now working in the government hospitals who, when they see a child who is born with differently abled needs, they give me a call and they say, okay, this wasn't expected, but the baby has been born with harlequin ichthyosis. Can you come in? And then I go in and see, okay, there is this very low income family who is standing there from a Kachi Abadi who has no idea what genetics even means or frankly even stands for. And then when I get talking to them, when I see the baby in the NICU, and to be able to explain to them that it's going to be okay, it's not going to be okay. The affordability, the taking care, the NG tubes, it is a long process. And then when I get talking to that family, I understand and I learn that the girl is 18-year-old who's just delivered, and this is the third Harley baby that she's produced. The first 2 died as soon as they were born, and this one has miraculously survived. Now, these are ground realities that we are facing. I'm not a certified counselor to talk in genetics or to talk from a medical field, but just from a understanding of emotions and of the kind of the stories and cases that we witness as a parent support body. I knew that I had counseled that family for hours on end that it is going to be okay. I knew that after 48 hours, when the baby was released, the baby, I'm going to hear soon enough, I'm going to hear that the baby has expired, or the baby has not been fed, or the baby has been left, or the baby has been abandoned. These are the ground realities that we are looking at. And clearly, after 48 hours, I got a call from the NICU at Lady Dufferin, and they said they've brought in the baby. And like you said, the baby is no more. Because there was no way that they were going to take that baby back into their society and be able to give an explanation to as what has happened. If that family had been given a little bit of counseling, and which they were after this baby, because I told the father that you have killed the baby in not many words, but I had sort of counseled him, and I said, listen, you need to go to the hospital and get yourselves tested. You need to find out what the problem is. This year, I was so amazed, and I'll share those photographs with you, Aisha and Myla. Uh, the set of parents who had had 3 Harley babies gave birth to a beautiful baby girl this year who had been treated for whatever they were fighting against, genetically treated, whatever they were fighting. And they were, again, a cousin marriage, but everything has a reason, answer, and we can deal with it. So yes, the responses and the attitudes are culturally motivated, they're culturally driven, and we need to be very, very sensitive. So sensitization is one of the biggest things that we are looking at, being very sensitive to family bodies and understanding what we need to teach them.
I would like everybody in this audience to really have that picture in your head or in your minds when you're thinking about genetics. That is what we're working towards. That is our goal and our mission and our aims in life, I think, is to be able to help that person get their genetic counseling and testing done so that they can be empowered to take care of their child with their differently abled needs. And that is so beautifully put, Rabia, thank you. I'm going to skip a couple of questions here because I think there are audience members that are eager to jump in. Please unmute yourself, Sagira Malik. Sagira, you have some things to say. Please go ahead. You have the floor for a minute or two.
Hi, Sagira Sharif. My name is Dr. Sagira Sharif, Dr. Sagira Malik Sharif. I'm a principal genetic counselor, and today I think I'm the only one maybe possibly presenting UK clinical genetics here. So I am from Yorkshire Regional Genetics. It's a department we are based at in the Lead Teaching Hospital NHS Trust. And I am currently a principal genetic counselor for prenatal genetics. And I will, first of all, I'll appreciate Dr. Rizwan for inviting me. And though it was a short notice, but I'm glad that I'm here and I've been listening. And I think I'm very pleased to see our young, enthusiastic genetic counselor here from state. And I think Aisha has contacted us a few years ago, if she may remember, from the clinical genetic at Leeds. So we have long-standing journey of developing and establishing clinical genetic in Pakistan. And because we are in the part of UK where we serve almost 4.3% of Pakistani population out of 4 million population in the Yorkshire region. So we have been heavily involved with most from the scientific and clinical aspect of genetic conditions with Pakistani population. And we have made some fantastic research and discovery of autosomal recessive condition and provided a direct clinical benefit to our families as well. With regard to prenatal genetic setup, we've been struggling with Pakistan, and Dr. Yasmin Rashid, who is our current Minister of Punjab Health Minister, she was the first one long time ago, about 25 years ago, which was trained by my department as a fetal medicine consultant as well. And the setup.
Thank you, Doctor. We have to cut you short. You have very valuable information. Please add it to the chat box.
Absolutely. I just wanted to say just one thing, just to reinforce Dr. Karmani's point that we have been setting up these efforts isolated in small pockets. I was trained by military, so I'm discussing this with them as well. It's important that we carry on these efforts in a uniform manner under one umbrella where all the efforts toward this setting up this clinical genetic.
Thank you, Dr. Sagira. Appreciate it so much. Dr. Jamal, can you please unmute yourself? Thank you. Dr. Jamal, can you please add your comments?
Yes, sorry, I just wanted to make a couple of very small comments. Just wanted to tell Rabia and others that we have put the first break of neonatal screening, and we have started a neonatal screening program of congenital hypothyroidism in the entire Sindh with the government help, completely free of cost. And we hope to build on the screening program to do more screening for other diseases. That was the first comment. The other comment was about the comment about what Kirmani was saying about certification. I think what he meant by certification was a certification of international recognition. Of course, that might take a little while, but short of that, we can still have some kind of a local certification from a university here, either JSMU, Aga Khan, Karachi University, whatever university locally, so that so whoever is trained will get at least some kind of recognition for their training, and then subsequently may go on to develop to have an international certification. Thank you.
Thank you. Myla, please unmute yourself. Myla, are there any questions from the audience that you think any of our panelists can spend the last 3 minutes on? And I'm going to put the...
Yes, I think maybe Dr. Ijaz Ahmed, can you please comment a little bit on training? Because there are some questions in the audience about whether it's a possibility to receive some sort of credentialing or training.
I'll just add something to the question. Ijaz, please also touch upon what are, some people would say, what is the point of studying genetics to practice or, practice genetic counseling when there's no cure for genetic disorders? So please amend that question into your answer.
A lot has been said, so I will be very brief. So the main thing is, of course, like Ms. Rabia said, that it's very important for families to know what the genetic problems are so that they can understand the gravity of the situation, understand what they should expect, and also this helps the physicians to properly manage these conditions, because a lot of these genetic disorders have comorbidities, and knowing what exactly it is helps to figure out what the patient may develop, and then just deal with that, and like Dr. Rizwan said, reduce the disease burden. Prevention is a big thing with knowing exactly what genetic diagnoses are, because like in cancer genetics, if you have a BRCA mutation, you can have high-risk screening, you can have prophylactic surgery, and literally save yourself from getting cancer. And those families are devastated by cancers, especially with hereditary cancer genes in colon cancer and other conditions. So it's very helpful to know exactly what's going on. And lastly, real quickly, treatment is available and is becoming rapidly available. There's gene therapy available for spinal muscular atrophy. There's gene therapy available for certain form of retinitis pigmentosa. So there's a lot being done. So it's very important that genetic diagnoses are recognized and then managed properly. So making a diagnosis is very crucial. As far as Myla's question is concerned about the genetics program from the attendees, right now, what we have here is genetic residency training programs. Like I said, that you have to have some other specialty before you do it. But electives are available for medical students who would like to come to the US and do electives in medical genetics. And I can identify certain programs that are available who accept children or students for those electives. So if you're interested, please send us a request at tsmg.org. There's an email there. And we'll try to help you as best as we can.
Awesome, great plug. And I'm sorry we have run out of time to address any more questions. All the questions that you have in the chat box, please email those to us at gcinpakistan@gmail.com. Alternatively, you can also go to www.psmg.org, and there's an email box there. Also, you'll get a lot of information from our email responses. I'm really, really, really sorry that we can't get to those questions. There is also a very, very important piece of this webinar, which is some additional survey questions that we have for the audience members. Please take the time to click on the link that Myla is going to put in the chat box and answer those questions. Please provide us with your email address at the least and your names so that we can contact you for further collaboration and further discussion. Finite amount of time with so much to go over. I want to thank all the panelists. I want to summarize very quickly in just 30 seconds. There's a strong need for genetic counseling and genetic testing and geneticists, and our panelists and our audience is geared towards that one goal and one mission, and advocacy groups and everyone involved is so passionate about it. And I'm so glad that we got together today. And thank you for taking 2 hours of your time on your Sunday evening for us. I really appreciate it. But please take a picture of this screen, take a screenshot of this, and don't forget to fill out the survey. Thank you guys so much.
Thank you, Aisha.
Thank you, everyone, and especially to Aisha for doing a wonderful moderation. And she has to get up like 5 in the morning on Sunday to be ready for this seminar, and Ijaz also. In addition, people from Pakistan, it's a Sunday evening and the only day off for them, for Dr. Raza and Dr. Kirmani and Hassan and Rabia and everyone. It's a start. I hope we will do multiple seminars. We will group together and focus it more on certain areas and move on once in a month, please. Thank you, everyone.
Fantastic work, Aisha, Mile, and everyone.
Thank you so much. So I'm going to end this meeting now.